Uh, Good afternoon, everyone. I know this is the last session of the day, so I'll try to keep it brief. It's difficult to be interactive with these meetings, but yeah, as I said, please interrupt me if you have any questions or we have a discussion at the end. So I'm going to focus on the effect of endometriosis on fertility. The idea for this talk came after I attended an ESTRE campus. ESTRE is the European Society of Human Reproduction. That was in January in Milan, before the whole COVID-19 pandemic. So I just did a systematic review to try to present to you the data that you need to manage patients with endometriosis and how to counsel them appropriately. Right, so the talk is going to focus on four aspects. First of all, we're going to talk about the association of endometriosis and infertility, and we're going to focus on numbers, on epidemiological data. So you can tell couples and tell women specifically about what is the exact effect of endometriosis on fertility and vice versa. Then after we finish this, we're going to focus on the management of patients with ovarian endometrioma specifically. So if you see a scan report or a CT saying raising the suspicion of an ovarian endometrioma, what do we do with those patients? Then we're going to move on the management of severe deep infiltrating endometriosis and focus on just a couple of slides on a new concept called the Endometriosis Fertility Index, especially those of you that work in Oxford. There's a lot of research now going on by Professor Becker, and they're actually using this index to manage patients with endometriosis and guide them towards IVF or spontaneous conception. And lastly, if we have time, we're going to talk about the impact of endometriosis on obstetric outcomes. Right. So one of the first questions you may be asked in the fertility clinic or in the gynecology outpatient clinic after a patient has been diagnosed with endometriosis is how many women actually with infertility have endometriosis. So if you see a couple in the fertility clinic and they ask you what is my chance of having endometriosis, what is your answer? And we're going to talk about the exact opposite after that. So we need to focus on big databases to answer this question. This is from the database of HFEA, the Human Fertility and Embryology Authority, from 2016. So if you look at this database, it tells you that about 10% of infertile women will have endometriosis. So this is this number here. These are all patients undergoing IVF, so subfertile couples. So 10%, which is actually a small number if you think about it. But if you look at the other causes of subfertility, like tubal disease or patients or couples with multiple male and female factors, there is a proportion of these women that have endometriosis as well. So there is a proportion of women with tubal disease, for example, that will have endometriosis. And there is a proportion of couples with multiple male and female factors that will have endometriosis. So if you add these numbers, this 10% number goes up to 20 to 25%. And this is backed up by big studies as well. This is from a study published in 2019 in the Journal of Minimal Invasive Gynecology. They did a massive systematic review over the last 30 years, from 1989 to 2019. And they studied cases with diagnosed endometriosis based on clinical or surgical visualization, with or without histological confirmation, and tried to find the prevalence of endometriosis in subfertile couples. And this is what they found. As you can see, it's not very helpful because it gives you a very variable, very wide range of prevalence. Between 9 to 68% of infertile couples will have endometriosis, as you can see. But again, if you take the mean number, they agree with the HFEA database and tells us that approximately 1/4 of subfertile women will have endometriosis. So this is a number that you need to remember. But what about the exact opposite question? How many women with endometriosis have infertility? So if you do see a patient in the emergency department or in the gynecology clinic, this has been diagnosed with endometriosis, either on a scan, MRI, or surgically, and they ask you, what is my chance of being infertile in the future? What can you say? So again, we have to look at big studies. This is an epidemiological study published in 2017 in the BJOG journal, and they included more than 2 million patients between 1998 to 2015. And what did they find, essentially? They found that about 1/3 of women with endometriosis suffers from infertility. You can see this number here. 37% of women who have been diagnosed with endometriosis will suffer from a degree of subfertility in their lifetime. Obviously, it's difficult to counsel women based on this number because it does not take into account the extent of endometriosis, the age of the patient, if there is any male factor. But as a number, you can say that about 1/3 of patients with endometriosis might develop subfertility in their lifetime and might need help, be it surgery or IVF, to conceive. This is another quite big study published by the World Endometriosis Research Foundation. One of our own was in the authors group, Stephen Kennedy, a professor in Oxford. They included 1,418 premenopausal women aged between 18 and 45 years. And the numbers that they found were actually quite consistent with the previous study. You can see here that about 33% of women with endometriosis presented with infertility. So again, about 1/3. But actually, they found something else that's quite interesting. It's on the top of this slide. It tells you that subfertile women with endometriosis will have some degree of pelvic pain. So patients with asymptomatic endometriosis, regardless of the degree of the disease, have a lower incidence of subfertility. And this is shown by these numbers here. So if they do have endometriosis and they have significant pelvic pain, dyspareunia, and other associated symptoms, their chance of developing infertility is higher compared to asymptomatic patients. Right, so what happens to fertility when endometriosis is left untreated? Obviously, it would be very difficult to do this study now because we're talking about infertile couples that have been diagnosed with endometriosis, and to tell them that we're not doing anything would be almost unthinkable nowadays. But actually, this study has been done, and it was published in 1995 in the Fertility and Sterility Journal, when essentially they included patients from 11 academic fertility clinics between 1984 and 1987. You can see that the mean duration of infertility was almost 3 years, which sounds quite ludicrous, but this study was published, and the mean age of the patients was about 31 years old. They divided patients to those who were treated with laparoscopy, not IVF, and those patients with endometriosis that were untreated, and then they followed them up for 3 years. These are the numbers. So they categorized patients based on their cause of infertility. We're going to focus on the last group here. So 14% of those patients were diagnosed with endometriosis. And what did they find? They found that actually over the years, there was a significant effect on fertility and live birth rates as endometriosis was left untreated. So you can see these are the months here. They follow them up for 84 months. There was a significant effect on cumulative live birth rates to patients that were not treated for endometriosis. So actually, when you do get infertile couples that have been diagnosed with endometriosis, you have to help them either with surgery or IVF if they have not been able to conceive spontaneously. And another interesting finding from this study, actually, other than what I just mentioned, is that endometriosis is as a significant factor in the lower conception rate group as the male factor, as you can see here, or even compared to women with tubal defect. It has a comparable effect on their fertility, which is actually quite important to remember. Another very important study is essentially what is the impact of endometriosis on IVF outcomes. This is a much more recent study from 2016 in the Fertility and Sterility Journal. So actually, if we counsel patients towards IVF, patients who have endometriosis, what is their actual chance of conceiving? And they included a big number of patients. Again, you can see here more than about 350,000 IVF cycles. It was very interesting that patients who have that the only cause of infertility was endometriosis, their success rates were comparable to women who have unexplained infertility. They have almost 45% chances of conceiving and having a baby, which is quite high. But if they had endometriosis and other causes of infertility, such as male factor or tubal disease, their chances of success dropped significantly to 35%. So endometriosis on its own did not have an effect on the IVF success rates, which is one of the reasons what we're going to talk about it later, why quite a few of these subfertile couples, if their only issue is subfertility and they have endometriosis, are guided towards IVF nowadays. Now, last question from this epidemiology section is there a temporal relationship between endometriosis and infertility? So if we see a young girl, age 20, 22, that has been diagnosed with endometriosis, has an endometrioma and other or peritoneal endometriosis, how many years will it be before she actually develops infertility? And has there been a study to help us decide that? There was actually a very, very interesting study published in the Human Reproduction Journal in 2016, which was a prospective cohort study of endometriosis and subsequent risk of infertility. They included a very big number of patients again, as you can see, 116,000, all of them American registered nurses, aged between 24 to 44 years old. They followed them up for 16 years, so a very committed group. And essentially what they did is twice a year from 1989 to 2001, and every 4 years thereafter, they sent them questionnaires and asking them had they tried to become pregnant for more than a year without success, and what were the reasons why they have not been able to conceive. And if they answered that they had endometriosis, has it been confirmed by laparoscopy? And what did they find? They found, even though they could not give us a number of how many years before endometriosis causes subfertility, they found a significant association between the incidence of endometriosis and their concurrent infertility over a 6 to 10 year period. So as you see the slide, if we use 1 as a baseline risk of the population, the general population to develop infertility, there was a twice as high risk of patients with endometriosis to develop infertility. And actually, if you just focus on women who have been diagnosed with endometriosis, what's the risk of developing infertility later on if you don't treat it? It can go as high as 3.23 actually. So up to 3 times as high for women with endometriosis to develop infertility over a 10-year period. But actually, this specific study had some very reassuring findings for women with endometriosis as well. It tells us that the vast majority of women with endometriosis were not infertile. So as you can see, that 74% of women, so 3/4, actually had a baby before the diagnosis of endometriosis. So actually were not treated and conceived naturally without any intervention. And that number goes up to 83% of women who actually had endometriosis and needed help to conceive and had surgery, and they had a baby by the age of 40. So up to 83% of women actually conceived with minimal intervention. And if you want to focus on groups that essentially might be more likely to develop infertility with endometriosis, it seems that if you're less than 35 years old, the hazard ratio is 1.7, and it was statistically significant. Lean women with a BMI of 18 to 22 had a hazard ratio of 1.9. And actually, if they had primary infertility compared to secondary infertility, if they've never been pregnant before, that has a stronger association with subfertility. So, to conclude with the first section of the presentation, there is an incomplete understanding of the etiology of endometriosis, and that makes it quite difficult to define its association with infertility. As you saw from the studies, they're quite heterogeneous, and the population studies are quite different, and that results in a variable prevalence of endometriosis, plus minus infertility. If you remember the second study, the prevalence was between 9 to 68%, so quite wide. But we definitely know for sure from these studies that there is an association between endometriosis and infertility, but this association is variable in terms of strength of association, consistency, and specificity. But the numbers that I want you to remember is that approximately 1/4 of women with infertility have endometriosis, so about 25%. If you see them in the fertility clinic, they're infertile, they might have endometriosis in about 1/4. And the opposite is about 1/3 of women that have been diagnosed with endometriosis will develop subfertility at some point in their lifetime. The chances of infertility, as we said, from the in 1996 in the United States, is increased by 2 to 3-fold in women with surgically diagnosed endometriosis over time. As we said, there is a paucity of data around specific stages and types of endometriosis, and it's quite difficult to actually design an epidemiological study focusing just on women with stage 3 or 4 endometriosis compared to women with mild endometriosis. So we just study women as a group having endometriosis. But it's important to remember that most women with endometriosis do not have infertility, and that most women with endometriosis will conceive successfully, either naturally, spontaneously, or by assisted reproduction. Right, so that's the first aspect, first section of the presentation. Do you have any questions, or shall I carry on with the second section? Okay, I'll carry on. So the second part of the presentation focuses on women that have been diagnosed with ovarian endometriosis. I think it's important from now on when we talk about women with endometriosis, and that is discussed in different groups by specialized doctors in endometriosis, is we talk about 3 types of endometriosis: either peritoneal, ovarian, or deep infiltrating endometriosis that involves the bowel, the retrovaginal septum, and other parts of the peritoneal cavity. So it's very important to remember that endometriosis is classified into 3 categories. But now we're going to talk about the impact of endometriomas with or without surgical intervention on IVF, ovarian reserve, and pregnancy rates. Right, so ovarian endometriomas are detected, as you can see, in about 17 to 44% of women with endometriosis. Their presence is very important, and we know, and if you talk to endometriosis specialists like Professor Becker or Praz in Oxford, they will tell you that the presence of an ovarian endometrioma might indicate severe deep infiltrating endometriosis. So actually diagnosing an endometrioma is actually quite important, because it tells us that if we're planning to do surgery, it might be a difficult surgery, and we might have to actually resect endometriosis, and the risk of complication is higher. We talked about the prevalence rate of endometriosis, and according to the CDC in the United States, patients with endometriomas are responsible for approximately 10% of the indications for IVF, and about 6% in the United Kingdom. So big numbers. So what we're going to focus in this section of the presentation is how does an endometrioma cause subfertility? Is it actually iatrogenic? Is it actually us doing the surgery that essentially has a significant impact on the ovarian reserve of women and actual subfertility? Or is it actually the endometriosis itself that has an impact on the ovarian reserve? And what is that actual impact? Right. So we know from studies that the presence of a cyst per se, the presence specifically of an endometrioma, distorts and exerts a toxic effect on healthy ovarian parenchyma, having a direct effect on ovarian reserve, ovulation rate, pregnancy rates, and even for women who go through IVF, on their ovarian response to stimulation. This is proven by big histological studies. This is by a Spanish study group. They published in the Human Reproduction Journal, and they found they studied on the cellular and molecular features of the endometriotic ovarian cyst, and they found that the cyst, the fluid of the cyst, contains reactive oxygen species, contains iron, inflammatory factors, and proteolytic enzymes, and it causes directly vascular injury and follicular entrapment and loss. So actually having an ovarian endometriotic cyst per se has a toxic effect on the ovarian parenchyma. This was confirmed by another study published in 2014 by this Japanese group. What they found is essentially having endometriosis in the ovary causes fibrosis and loss of cortex-specific stroma, leading to enhanced recruitment and atresia, and leading to dysregulation of folliculogenesis. And that's why we find, and I'm going to show that to you in the next slides, that there is a reduced AMH level and reduced amounts of growing follicles in women with endometriomas. Now, that's how an ovarian endometrioma causes direct effect on the ovary. But what about us? What about the surgical treatment of endometriomas? Does that cause any injury to the ovary? It has been actually widely reported in the literature that there is surgery-mediated damage on the healthy ovarian parenchyma. This Italian group, Muzzi, is a professor in Rome, showed that there is actually, when they studied the specimens after an ovarian cystectomy, there was also coming with the cyst, there was a removal of healthy tissue as well surrounding the cyst. Another Spanish group confirmed the same, that there was surgery-related inflammation. Also, there was vascular compromise due to excessive coagulation. And there was also kind of an interesting study, again published by Professor Muzzi, that showed that there was an association between the technical skills and the ability of the surgeon and the actual damage to the ovary during that operation. So now focusing on the ovarian reserve, we know from studies that there is a lower rate of spontaneous ovulation in unoperated ovaries carrying an endometrioma. So even if we don't do anything, if we don't do any surgery, there is a lower rate of spontaneous ovulation if there is an endometrioma in that ovary. And this Turkish group, they published this study, they called it ERROR. Who knows why? And they found that there is, having an endometrioma is associated with a progressive decline in ovarian reserve and a progressive reduction in the AMH serum levels. That's even without doing any surgery. This Italian group showed that the ovarian reserve, if we evaluate it with the AMH, the anti-Mullerian hormone produced by the granulation cells of the ovary, is reduced in patients with ovarian endometrioma, compare not just to patients who do not have any ovarian cysts, but to patients who have other types of benign ovarian cysts. And there is definitely a reduced AMH level in those patients. What about surgery? It has also been widely published, and I'm mentioning the studies here, that there is a surgery-mediated decline in serum AMH levels after surgery. And actually, there is a progressive decline even after 6 months of follow-up in the AMH levels, but it seems that the AFC, the antral follicular count, remains unchanged. But actually, in the fertility clinic, we use AMH as a more accurate factor of ovarian reserve compared to AFC. There is a decline in AMH levels. It may be temporary, and there haven't been many studies who follow up these patients for more than 12 months. And we need to remember the patients that have bilateral endometriomas that the serum AMH decrease is much more prominent, and we have to counsel these patients about the higher risk of premature ovarian failure if they undergo surgery of cystectomies for bilateral endometriomas. And this is, as I said, based on these two studies. This is just a number that you need to remember, especially for the Part 2 MRCOG exam. So if you do find a patient in the clinic that has been consented for endometriosis surgery and they have been diagnosed with bilateral endometriomas, they have to know that laparoscopic excision of bilateral endometriomas comes with a risk of 2.4% risk of premature ovarian failure. Another study says that that risk is 1.7, but the most common number that we use is 2.4%. What about the pregnancy rate? What's the effect on the pregnancy rates if a patient has an ovarian endometrioma? We know that if we have a patient with an unoperated endometrioma, if we don't touch them, they do have a higher cycle cancellation rate. Now we're talking about IVF patients, and they do have a lower formation of embryos and blastocysts. But actually, if they go through IVF with an ovarian endometrioma, the clinical pregnancy rates and the live birth rates were not statistically different. And it's actually quite important to remember that women undergoing IVF, having a unilateral endometrioma, their response to medication and to hormones, like FSH injections, did not differ markedly between the affected and the intact gonads. But if the cyst is more than 5 centimeters and if they had bilateral cyst, there is a definite reduction in ovarian responsiveness. That's quite important to remember, and I'm going to explain that later, why for patients who are subfertile and all they want is to conceive, most of the times, and you'll see that in the fertility clinic, we do not advise surgery for an ovarian endometrioma. We counsel them to go through IVF if they have not been able to conceive. Because as I told you before, surgery can reduce their AMH even more. And actually, if you see that if they go through IVF, the clinical pregnancy rates and live birth rates are not lower than women without an endometrioma. Exclusion to that rule is if they are complaining of pelvic pain. If they have significant pain and they have an ovarian endometrioma, the national guidelines say that we should offer a cystectomy, but not if they just want to conceive. This is backed by this study. I just uploaded it for you to study. It shows that the live birth rate and pregnancy rates are exactly the same. There's a slightly higher number of cancellation rates and lower number of the number of oocytes that were retrieved during IVF, and perhaps the FSH dose needed might be slightly higher because of the reduced response to hormonal medication. Now, in terms of, there's some studies that essentially study the clinical relevance of these reduced ovarian markers, and is that significant for the patients? There's a very nice Cochrane study published in 2013 that first of all showed that doing laparoscopic surgery for mild to moderate endometriosis is definitely associated with a higher ongoing pregnancy and live birth rate. This is not for patients with ovarian endometriomas. It's patients diagnosed with mild to moderate endometriosis. So in these cases, we should be considering surgery. Now, the pregnancy rate among surgery compared to patients who have surgery and then go through IVF is exactly the same, and it has not been statistically significant, according to this very recent study. And we know, as we said, that there is a poor response to ovarian stimulation, even if the fertilization rates and high-quality embryos are the same compared to patients with an unoperated ovary. The pregnancy rates for those patients reaches up to 41%, and this is with IVF and laparoscopic surgery, something we should be advising patients. So this has got a large body of evidence. I just want to focus now on the important aspects and how to manage these patients. We have to be categorizing these patients into patients with subfertility and with pain. As I told you, and as the evidence suggests, is that these patients have a reduced AMH level. Patients with ovarian endometriomas have reduced AMH levels even before we operate, And if we operate, we might reduce their AMH even further. So we have to be asking the patient, is that endometrioma causing any symptoms? If it's not causing symptoms, and if they're not trying to get pregnant, we should be considering hormonal contraception. If they're trying to get pregnant, we should be considering IVF. But we should not be advocating surgery for patients with ovarian endometriomas that are asymptomatic. Now, if it causes significant pelvic pain, we should be offering an ovarian cystectomy. As I said before in the beginning, thinking that having an ovarian endometrioma might be there might be associated deep endometriosis at the same time, so the surgery might be more difficult than initially anticipated. And we should be thinking about the potential effect of an endometrioma in the pregnancy and what complications might that have. And we're going to talk about the effect of the potential effects of an endometrioma in the pregnancy. What do the national guidelines say? This is the evidence from the ST1-2 guideline. It tells us that in patients with endometrioma measuring more than 3 centimeters, surgery is only recommended before IVF to reduce pain, to reduce the risk of infection during oocyte retrieval, or to facilitate access to follicles. However, there is no evidence that offering a cystectomy prior to IVF improves pregnancy rates. So as I said, if the couple is just trying to get pregnant, we should be referring them for IVF, not for cystectomy. What do the NICE guidelines say? That if we do perform surgery, we should be offering an ovarian cystectomy, not a drainage, with excision of the cyst wall to women with endometriomas, because that improves the chance of spontaneous pregnancy, and it also reduces recurrence. We should be adapting a more conservative approach in cases of asymptomatic patients, in older patients, and patients when we have an established low ovarian reserve. Now, as you notice from the NICE guideline, if you do have a patient that essentially does not fulfill the criteria for NHS-funded IVF, and they do have an ovarian endometrioma, and they want to conceive, they've tried for 12 to 24 months and they haven't been able to, we can offer cystectomy, and there is evidence that this can increase the chance of spontaneous pregnancy. But as I said, if they fulfill the criteria for IVF, we should be advocating IVF. In terms of how to do, what is the technique to do a cystectomy? We should be identifying the right dissection planes. We should be doing very delicate maneuvers and avoiding tearing. In that conference, we talked about the different techniques of dealing with an ovarian endometrioma. As I said, in quite a few specimens, there was a big study over a 2-year period. They found that there was healthy ovarian stroma in 80% of endometrioma cystectomies, compared to only 17% to women who went cystectomies for a dermoid cyst, for example. So we do tend to remove a lot of normal ovarian tissue when we do a cystectomy for an endometrioma. And that was confirmed by Muzzi and Exakostos in Italy and Portugal. One last thing about endometriomas here, in terms of the technique. As you know, the most common technique that we use is an ovarian cystectomy, trying to de-roof the whole cyst wall. But actually, there's a lot of studies on plasma energy who have less thermal spread on the parenchyma of the ovary and cause less fibrosis. And there's even more evidence about using the carbon dioxide laser for the endometrioma treatment. As you can see here, that's the thermal spread here. Doing a cystectomy, we might actually affect the ovarian parenchyma and cause fibrosis. But by using a carbon dioxide laser, and how to do that, essentially, you do partial cystectomy and you just cauterize the base of the cyst. It could be much more beneficial to those patients. But according to ST1-2 guidelines, according to the evidence that we have, there's a slightly lower recurrence rate doing a cystectomy compared to the carbon dioxide laser. So maybe this is an area that more research is needed at the moment. And these studies just prove the exact same concept that I just mentioned earlier. Yeah, this is just videos. If any of you is interested, it shows you how to do the stripping technique for an ovarian endometrioma, or how to use the laser carbon dioxide to treat an ovarian endometrioma. So essentially, you drain it, you do a partial cystectomy, and burn the base of the cyst without removing the base of the cyst completely. to reduce the risk of removing normal ovarian tissue. I'll just move on here because I'm conscious of the time. So, as I said, we should be thinking about fertility preservation and about the effect on AMHs after doing surgery, especially for women who are young and that do not have any immediate pregnancy desire. We should not be advocating surgery. Women who have bilateral endometriomas, we should be thinking about the risk of premature ovarian failure, which is, as we said, is 2.4% if we do surgery for bilateral endometriomas. And women who had previous surgery. And according to study, there was a big Scottish group that published that women with endometriosis in their lifetime have 2 to 3 surgeries. So quite a few of these women do tend to have repeated surgeries. And actually, if they do have endometriomas, we should be thinking twice before operating because of the effect on their ovarian tissue. So to conclude with, the impact of endometrioma and its surgical treatment remains controversial. The damage may precede surgery. The endometrioma itself may cause negative effects on the surrounding tissue. According to studies, to perform ovarian cystectomies, we need experienced surgeons and an appropriate technique. And carbon dioxide fiber laser ablation is a promising method to treat endometriomas, but more research is needed at the moment. Right, so just another 10 minutes to focus on women with deep infiltrating endometriosis. Okay, thank you, Paulginda. Right, so in terms of deep infiltrating endometriosis, so this is a big group of women that that can be you can see them either in the fertility clinic or in the gynecology clinic, particularly in departments like in Oxford that manage patients with chronic pelvic pain. A big percentage of these women will have deep infiltrating endometriosis. But now we're going to focus just on their reproductive outcomes and what to do, what type of, do they actually need surgery, and actually what type of surgery do they need, or should we be following a more conservative approach for those patients? Right, to understand about endometriosis, we need to remember about the pathophysiology of its associated infertility. As I told you before, always remember to classify endometriosis into peritoneal, ovarian, and deep infiltrating endometriosis. We talked about earlier how ovarian endometriosis has a direct effect on the fertility of the patient and on their ovarian reserve. How does peritoneal endometriosis cause infertility? Quite a few times we operate on patients, we do a diagnostic laparoscopy, and we find these tiny peritoneal lesions on patients, and then is it easy to wonder how do those tiny lesions cause infertility? But actually, there's been a lot of evidence that these small lesions cause toxicity of the peritoneal fluid. If you took a sample of this peritoneal fluid and send it for cytological assessment, it's full of cytokines, inflammatory factors like TNF-A, and this inflammatory peritoneal environment can have a direct effect on the egg quality and folliculogenesis, and it can have an effect on the endometrial receptivity and luteal function. And that's why, as I said, from the Cochrane review published in 2014, there is significant evidence that treating this mild endometriosis can increase spontaneous pregnancy rates. So that's how peritoneal endometriosis causes subfertility, and deep infiltrating endometriosis now causes subfertility mostly by distorting the normal anatomy, by causing tube ovarian adhesions, and causing altered ovulatory function by destroying the ovarian tissue. And something that we always should remember, sometimes it's not talked about much with these patients, is that quite a few of patients particularly with severe endometriosis, have associated adenomyosis as well, which is endometriosis in the muscle of the uterus, and that can have a significant effect on infertility as well, and chronic pelvic pain. Now, an important concept and something that it is being discussed in endometriosis groups is that essentially, what is the actual causal relation between severe endometriosis, particularly colorectal endometriosis, and infertility? And it might be possible that the association may not be as strong as initially suspected. And it might be that the ovarian or peritoneal endometriosis or adenomyosis that these patients have, and also the associated dyspareunia that it might cause, it might be more important than the deep infiltrating endometriosis alone. That is quite important to remember, because it helps us as clinicians decide to actually, is it better to treat these patients conservatively, or do a simpler surgery just to restore the anatomy, or do we have to completely excise endometriosis? And sometimes that might mean doing bowel resections to actually either treat their pelvic pain or help them conceive. So we need to be thinking about the pathophysiology of the disease before we decide on what type of surgery or what type of management they need to have. So this is from the ESTRE guidelines that I keep quoting, because they are evidence-based guidelines. So as I said in the beginning, we should be classifying patients with endometriosis to those who have infertility and to those who have endometriosis-associated pain, being pelvic pain, dysmenorrhea, or dyspareunia. The first line of management should be hormonal treatment. As you can see, be it progestogens, antiprogestins, or GnRH agonists. Now, if the hormonal contraception fails, then we should be considering surgery. But in terms of this surgery, as you can see here, it should be essentially in a center of expertise, because it can be quite significant surgery. But there is evidence here, although it's not strong evidence. The evidence is B, as you can see, that doing surgery and removing those nodules of endometriosis, it can reduce endometriosis-associated pain, and it can improve quality of life. And what's more, in those patients with deep infiltrating endometriosis, if you just think about their fertility, there is evidence here, but again, you see that the evidence is not strong, is B, but there are two high-quality prospective cohort studies that in patients with moderate endometriosis, their spontaneous pregnancy rates go from 33% to 57 to 69%. And if they have severe endometriosis, it goes from 0% of spontaneous pregnancy to up to 68% if you operate on them. But again, as I said, this is not strong evidence, but two studies have actually shown that. What does ESTRE say? The official ESTRE guidance, and if you go to any fertility clinic, that's what the fertility specialists advise women with deep infiltrating endometriosis if they just want to conceive, is that for infertile women with deep endometriosis, there's no significant evidence to recommend surgical excision prior to IVF to improve reproductive outcomes. So that means if you just have a patient diagnosed with endometriosis and they just want to conceive, you should refer directly for IVF. Now, if quite a few of these women often suffer from pain as well, and they have pelvic pain, in this case, because as I said from previously, it can increase, doing surgery can increase the spontaneous pregnancy rates, and it can also reduce the endometriosis-associated pain, we should be offering surgery. But again, if they just want to conceive, and bearing in mind the high complication rates of doing this type of surgery, we should be advocating IVF. And only if they have more than 2 to 3 failed IVF cycles, we should be advocating surgery. And I just sum up this evidence in this slide. Something that I just wanted to mention, and you might find if you do a literature research in this field of colorectal endometriosis, even though there are quite a lot of studies published, 470, if you just look at the high quality evidence, the randomized controlled trials, there's only 8 items. And if you really look at the well-designed studies, there are only actually 2 studies. So there's plenty of research going that should actually continue in this field of medicine. The 2 studies that I talked about is those 2. The first one was a randomized controlled study studying whether we should be doing laparoscopic or open surgery for colorectal resection of endometriosis. and they essentially found that we should be doing laparoscopic resection. And then there is this study by this French group. Horace Roman is one of the most famous endometriosis surgeons. And they essentially compared conservative surgery versus colorectal resection in deep endometriosis infiltrating the rectum. And they found that this during colorectal resection can have a much more significant effect in relieving endometriosis-associated pain. And another thing that was proven by Dr. Roman is that doing this type of surgery can increase their spontaneous pregnancy rates as well. Even though they had small numbers, 36 patients, 20 of those patients tried to conceive spontaneously, and 17 of them, as you can see, 17 out of 20 conceived naturally. But also quite a reassuring factor is that the 16 patients who went for IVF, 12 of them conceived. So again, quite high numbers. Quite a few of those patients conceived either with assisted reproduction or spontaneously, and this is something that we should be telling women to reassure them. Right, so I'm just going to move on from those. This is a systematic review based on this subject. The only thing I just wanted to mention to you is that how high the complication rates can be by doing surgery for deep infiltrating bowel endometriosis. The usual number that we quote, the intraoperative complication rate is about 2 to 3%, and the postoperative complication rate is 12 to 14%, as you can see, and that's proven by those studies. But if you see this study, for example, published by Roman, when they did disc excisions using the Rouen technique, the total major complication rate is about 26%. And in these cases, we talk about stoma formation, we talk about major bladder injuries or ureteric injuries, injuries that can have a significant long-term effect on women. That's why we should be thinking twice if we do this type of surgery, and it should be done in specialized centers. We should be thinking what is the aim of the surgery for this type of endometriosis is to control the associated pain. And if they just want to conceive, maybe we should just be focusing on restoring the anatomy rather than completely excising the endometriosis from the bowel or below the uterus or from the vagina. So as a conclusion, the causal relation between colorectal endometriosis and infertility may be less strong than for other forms of endometriosis, such as peritoneal or ovarian, as we mentioned. Surgery should be done only when indicated, just to restore anatomy and aimed mostly at the ovary and the peritoneum. Maybe we should be reconsidering overly aggressive surgery and leaving some disease behind, knowing that it would not have an effect on the patient's fertility. And always the patient preference should be at the heart of the decision. Just the last aspect, just the last thing that I wanted to mention is the endometriosis fertility index. Again, as I said, it's being used at the moment in Oxford by Professor Becker and Fraz. This is an index used by reproductive surgeons to essentially counsel women towards IVF or spontaneous pregnancy. This is calculated after doing surgery, laparoscopic surgery for endometriosis. We should be actually staging the disease. We should be focusing mostly at the ovary and the fallopian tubes, and then combined with the history of the patient, we come up with this endometriosis fertility index. And essentially, the higher this index is, the higher the chance for those patients to conceive spontaneously after laparoscopic surgery. Now, if that, and that's proven by this slide here, as you can see, if they have a score of 9 to 10, they have about 75 to 80% chance of conceiving spontaneously after laparoscopic surgery for endometriosis. But if they have a very low score, their chances of conceiving is up to 5%. So we should be essentially counseling them towards IVF after laparoscopic surgery if the score is very low. And that's based on the age of the patient, on the laparoscopic extent of the endometriosis, and the history of the patient. This is just to tell you that this is a freely available score. It was published in the Fertility Sterility Journal and is easily calculated. But we should be aiming to stage the endometriosis, even if we don't perform surgery for deep infiltrating endometriosis. If we do diagnose it at a laparoscopy, we should be essentially describing the full extent of endometriosis during surgery. And this is how this score is being used. It started in Belgium at the University of Leuven, and this is how essentially they guide patients. If they have a high EFI, they guide them towards spontaneous conception, and only if that fails after 6 months, they guide them towards IVF. But if they have a low index, they guide them towards IVF. That's all I wanted to say. I know we didn't get to talk about the obstetric outcomes. I just want to show you this one last thing about what the potential effect of an endometrioma can have on the pregnancy. So this is how a typical endometrioma looks like. It has this ground glass echogenicity, but this endometrioma can change during pregnancy. I just wanted to let you know about this concept called decidualization of an endometrioma during the pregnancy, which essentially, what is this decidualization? It occurs when the progesterone action increases the glandular epithelial secretion. So that can be a normal, essentially, change during pregnancy, but it can happen in the ectopic endometrium, and it's particularly inside the endometrioma as well. The important thing to remember is that a decidualization of endometrioma can look even like ovarian cancer. So you can see these papillary projections in an endometrioma during pregnancy. That's even more so in this picture. You can see these papillary projections, and sometimes they can even be confused with solid components, and even they can be extremely vascular as well. But we should be remembering that endometriomas can be decidualized, and we should not be confusing them with ovarian cancer, particularly if diagnosed during the pregnancy. And these patients should have a scan by a specialized radiologist or a specialized gynecologist in endometriosis. That's all. Thank you.
Thanks, Alex.
Sorry, I just stopped sharing my screen.